So certainly one of the fundamental expectations that patients have of healthcare professionals is that they tell the truth and secure patient consent, informed consent, before engaging in any procedure. Let's think about these obligations a bit more deeply. Maybe the place to start is to think about lying. What is lying? Well, to lie is to knowingly offer false information with an intent to deceive. The knowingly there is important. If you communicate false information but didn't know that, then clearly you've made a mistake, but you haven't lied. Now, why is lying thought to be wrong? First, as I have suggested in discussing autonomy previously, lying seems to always involve manipulation. Manipulation of the other person's freedom to think, choose, value, and act for themselves. We tell people what we want them to believe rather than what is actually the truth because we want to influence their choices and their behavior. Clear violation of their right and their capacity to govern their own lives. I think we might also say that lying and deception also often do harm to other people. It undermines the trust that's essential to human relationships, the trust that is particularly important in the relationship between the healthcare professional and the patient. And it may lead to a patient making choices that are not truly in their own best interests. So the lie hurts them. Now, some people say, okay, of course we shouldn't lie. But what about deceptive silences? Or what we might call misleading, but not actually false statements. Neither of these would seem to violate the rule against lying. And it raises the question, are we as human beings, are we in the special situation of the healthcare professional to patient relationship, are we required to correct misunderstanding that we didn't necessarily create? Now, the important consideration here is the intent to manipulate through deception. Whether we act to deceive or whether we say nothing, if our intent is to deceive, it may have the same morally problematic features. It may still involve a significant manipulation and therefore a violation of the principle of autonomy. Higgs puts it this way on page 48 of our textbook in his essay on telling the truth to patients. He writes, "It is, of course, quite possible and very common in clinical practice for doctors or nurses to engage in deliberate deceit without actually saying anything they believe to be false. But given the special responsibilities of the doctor and the relationship of trust that exists between him and his patient, one could hardly argue that this was morally any different from telling outright lies. Surely it is the intention that is all important. We may be silent, tactful, or reserved, but if we intend to deceive, what we are doing is tantamount to lying." Now, a couple of things to notice here. First is Higgs's claim that deceptive silences or misleading statements that deceive are equal to lies is grounded in his sense of the special relationship that healthcare professionals, he only mentions physicians and nurses, but I think it applies to all healthcare professionals, the special relationship they have to patients. What we might find tolerable, or at least permissible, in terms of deceiving through silence or misleading but not false statements, what we might find permissible or tolerable in an ordinary human relationship he says we should not find tolerable in the relationship between healthcare professionals and their patients. Why? Because our patients are so profoundly dependent upon us for the information we need, true information that we need to make good healthcare decisions. Related then to this strong obligation not to deceive, either through lies or misleading silences, is a strong obligation to tell the truth. Now, the obligation not to lie is negative. You fulfill it by doing nothing. But Higgs is pointing to a positive obligation to promote understanding, that healthcare professionals in their relationship to patients have an obligation to promote understanding. That is to say, they have an obligation to tell the truth, to disclose the information relevant to the situation they believe to be true. Now, generally, I think we might think that such a positive duty is imperfect or weaker in comparison to the duty not to lie, comparable to that relationship we've spoken of between non-maleficence and beneficence. But the point to be made here is that professional contexts strengthen the obligation to tell the truth, possibly making it perfect. We legitimately expect professionals to disclose relevant information. That's a part of our legitimate expectation of them. Healthcare professionals have this as a duty of fidelity. It is interesting, however, to note that traditional codes of medical ethics seem to be largely silent on the matter. And more significantly, and reflecting the realities behind that silence in the codes, is the practice of paternalistic lying or deception in the professional-patient relationship. Paternalism refers to treating someone thought to be childlike with paternal or parental concern for their welfare. In a paternalistic relationship, duties of non-maleficence to protect or beneficence to protect a person from harm are thought to outweigh those related to autonomy. Well, historically, physicians in particular often treated patients paternalistically, and on the basis of that paternalism, thought it justified to sometimes deceive them by telling them less than the whole truth. And let's consider some examples. We might fail to disclose or lie about a bad diagnosis to prevent a harmful psychological reaction that might undermine therapeutic goals. The argument might be the truth is only going to hurt them. We're going to do what we're going to do to make them better. There's no need to tell them the truth. Another example would be a failure to disclose or to lie about the side effects of some treatment option, which the healthcare professional believes to be best, but he or she is silent about those side effects or even denies the reality of those side effects in an attempt to encourage the patient to choose this treatment plan, which the healthcare professionals believes is in their best interest. Pure examples of paternalism, overriding patient autonomy as we would a child's autonomy with a good moral intention to protect them from harm or to promote their welfare. It remains paternalistic nonetheless. Higgs notes that a common justification in the past for physician non-disclosure of certain relevant information was the claim that medical information is difficult to communicate. It's complex and difficult to communicate and make understandable to patients without a medical background. He quotes this from a New England Journal of Medicine article in 1935. A patient has bowel cancer. With surgery, it might be cured or it might recur. Can the patient understand the side effects of treatment? The symptoms she is now getting might be due to cancer. There might be secondaries, and they in turn might be suppressible for a long time or not at all. What future symptoms might occur? How long will he live? Or how will she die? All these are desperately important questions for the patient, but even for her doctor, the answers can only be informed guesses, an area where uncertainty is hard to bear. So the idea here that this physician is saying, given the uncertainty of all this, given the difficulty of all this, it's acceptable, and maybe even better, simply to keep quiet about it. Higgs cites two other common reasons offered to justify deception. He says patients don't like to, or sometimes it's said, that patients don't like hearing bad news and don't really want to know the truth. Interesting, an argument here that appeals to patient autonomy. We're not telling them because they really don't want to know. And then a third argument is that the truth can in fact be harmful to patients. It can be harmful in the sense of causing them distress. It can be harmful in the sense of undermining their hope. It can be harmful in terms of making their approval of useful therapies unlikely. Now, Higgs cites these three arguments as ones that have been typically made to justify paternalistic lying or paternalistic deception. But be clear, he thinks they are all wrong. For example, Higgs thinks it profoundly mistaken to argue or to believe that the difficulty of explaining medical truth justifies deception. The difficulty of knowing and telling the whole truth is irrelevant, he says, with respect to both our intention not to deceive and telling what we do in fact know. He says this, whether or not we can ever fully grasp or express the whole picture, we must speak truthfully. It's hard to see how a patient can have autonomy, can make a free choice about matters concerning himself without some measure of understanding of the facts as they influence the case. And that implies, under normal circumstances, some open, honest discussion with his advisors. The whole truth may be impossible to attain, but truthfulness is not. I don't know can be a major piece of honesty. To deprive the patient of honest communication because we cannot know everything is not only confused thinking, it is immoral. Thus deprived, the patient cannot plan, he cannot choose, he cannot plan, he cannot choose. Bottom line here, I think, is that Higgs would insist, and I would agree, that among the significant skills that a healthcare professional must have is the skill of communicating as honestly and as informatively as is possible with the patients before him or her. That's an essential skill for a good healthcare practitioner. Higgs also responds to the two other typical arguments. He says, in fact, studies show that while some do reject or deny truthful information, most patients insist that they do want to know bad news. So this idea that we are actually somehow respecting their autonomy by withholding bad news, he says, does not bear up under scrutiny. Patients do want to know, even if the truth is unpleasant. And then finally, he says, the medical harm to patients is grossly overestimated. The occasions when a patient goes into depression or makes awful choices on the basis of an inability to deal with bad news are exaggerated. And he says the benefits, both medical and non-medical, to knowing the truth, even the unpleasant truth, are typically overlooked. Those medical benefits have to do with being able to make better choices medically. And the non-medical ones have to do with dealing in one's whole life with the reality of a bad situation in non-medical ways that are to the benefit of the patient. You should look carefully at Higgs' discussion of all this on the bottom of page 52. I noted that traditional codes of ethics in the medical professions tended not to mention deception and truth telling. That is no longer the case. So, for example, the pharmacy code says a pharmacist has a duty to tell the truth. And while there's no specific mention in the nursing code about honesty, the commentary mentions that the virtue of honesty is essential to good nursing practice. The music theory code says that the music therapist practices with integrity, honesty, fairness, and respect for others. And maybe most importantly of all, the Physician's Code of the American Medical Association says a physician shall be honest in all professional interactions. So this modern emphasis on truth-telling in medical practice is consistent with a solidly established legal and moral concept called voluntary informed consent. According to the doctrine of voluntary informed consent, medical interventions are morally and legally valid only if a competent patient gives voluntary consent based on relevant information and an adequate understanding of that information. So look what you must have. You must have a competent patient, one who is capable of understanding and weighing out risks and benefits, has a consistent set of values to which they apply their decisions. A competent patient or a competent decision maker, surrogate decision maker, such as a parent for a child or a designated family member for an older patient. That competent patient or surrogate decision maker must give voluntary consent. They have not been coerced or manipulated to give their consent, and that consent is based on relevant information. It's informed consent. Now, most would add it's not enough that healthcare providers provide the information for the requirement to be met. There must be reasonable certainty that the decision maker has an adequate understanding of that information to be able to make a competent decision. Now, one of the worries among many folks in medical ethics is that too often healthcare providers take a legalistic approach to voluntary informed consent requirements. They think, well, what is the information I must disclose to meet the requirements of the law? What forms do I have to get signed? How can I avoid a lawsuit? Sometimes you will actually hear healthcare professionals ask, have you gotten consent? By which they simply mean, have you gotten the form signed? The form that would keep us from being charged with assault for having given treatment or provided treatment against a person's will or without their informed consent. That sort of approach does not meet the moral nature of informed consent. Look at this passage from a handbook for healthcare ethics committees that we use at Winchester Medical Center. It says, by its nature, true informed consent is a process, not a moment in time. Not that moment in time when you get the signature on a piece of paper. Not a moment in time, not a perfunctory discussion or a signed document. Meaningful consent is voluntarily and knowledgeably given by the patient, not secured or imposed by the staff as part of an assignment. Consent is not something the physician extracts from or does to the patient. You need to get consent from Ms. Simon, or I consented, Mr. Thomas. This attitude violates the autonomy of the patient and makes the signed consent form a trophy rather than the documentation of a process of communication, education, understanding, and trust. Informed consent as a moral matter is a matter of communication, education, understanding, and trust. Or consider this passage from the essay from the President's Commission on Biomedical Ethics on page 66 in our text. Ethically valid consent is a process of shared decision-making based upon mutual respect and participation, not a ritual to be equated with reciting the contents of a form that details the risks of a particular procedure. So what is the information? What is the kind of truth that needs to be communicated, understandably, to the patient so that a patient can participate in decision making and give voluntary informed consent? Again, the handbook for ethics committees that we use at Winchester Medical Center has this helpful list. Patients should understand facts about the proposed diagnostic or therapeutic intervention, facts that a typical patient would consider relevant, all information that the physician considers important, information about the consequences of non-treatment. Okay, so this is what we expect to happen. These are the percentages if we go with this treatment. What happens if we don't treat at all? And are there other treatment options that have a different set of benefits and risks? And finally, informed consent does involve the physician's own recommendations about how he or she would balance the benefits and risks of an intervention. One of the things I want you to pay particular attention to is what the President's Commission says are the values or principles underlying this doctrine of informed consent. You can find this on pages 64 to 69. I find their discussion particularly interesting because it begins with patient well-being. It mentions patient autonomy or self-determination, but I find it interesting and significant that they begin with patient well-being. Now, why is that the case? Why do I find that interesting? Why do I draw your attention to it? I think, as our discussion so far would suggest, that the primary concern that we typically address when we talk about truth-telling and keeping patients informed and involving them in decision-making, the key consideration is typically patient autonomy. Now, the President's Commission includes that, but I find it quite interesting that they begin with patient well-being. I think they want to send a signal undermining those paternalistic sorts of non-disclosures we've talked about. They want to emphasize to healthcare professionals, you can't indeed promote your patient's interests most effectively except through the provision of proper information understood well by your patients. They offer two reasons for that. First, they say that often there are no objective medical criteria for determining which among multiple treatment options is best. The one that may be best may be from the subjective perspective of the patient himself or herself. So it's not as if the physician's preferred treatment is necessarily the treatment that is best for this particular patient, given that that patient knows the reality in their own lives, knows their own values, which may be different in some respects from the physician's. Since only the patient has that knowledge, only the patient can truly make the choice that best promotes their interests. So from the President's Commission perspective, it's patient well-being that is the first and fundamental basis for the practices of informed consent. Finally, I want to draw your attention to possible limits to the disclosure of information that the President's Commission mentions. The first one, I think, is most significant and most valid. They insist that a physician is under no obligation, or a healthcare professional in general, to discuss alternatives from outside the bounds of good medical practice. Yes, surely you must tell your patient about all alternative treatment options that are considered valid within the standards of your profession. You are not obligated to tell them about alternative procedures, alternative therapies that have not been verified and authorized within the practice of your particular profession. About that, the President's Commission, I think, is on solid grounds. The second one is more interesting. The alternatives offered and discussed do not need to be those that violate a professional's own deeply held moral beliefs. It's not terribly clear what they mean here. I mean, we're going to talk about a pharmacist's, pro-life pharmacist's refusal to write morning after pill prescriptions. Would this mean that a pharmacist in consultation with a patient would not be expected under informed consent criteria to even tell a patient about that option? If so, I think the President's Commission has gone too far here. If they mean simply an expansion of point 1, the physician is under no obligation to tell you about alternatives that violate his or her morally held, deeply held moral beliefs because it's outside the practice of good medicine, then I think they're on better grounds here. They also suggest that a physician is not obligated to tell you about alternatives that draw upon resources to which the patient has no binding claim. Does this mean, are they suggesting that the physician should not tell a patient about alternatives not covered in their insurance plan, for instance, alternatives which the physician believes the patient would have no ability to pay for? Again, if they're suggesting that that limits what a physician is obligated to tell a patient, I think that's much more questionable. Interesting thing here, though, for sure, is that like everything else, even informed consent has some morally legitimate limits.